Hi, this is Vic Gatto. Thanks for watching the Health Storm. Today I have Robert Longyear. He's the VP of Digital Health Innovation at Wanderly, but he's also an author, and he's done a ton of research around payments and value-based care. He's a really sharp guy who's done a lot of research in areas that are super interesting. It's a really good show. Please watch. Again, Vic Gatto with the Health Storm. Thanks. Okay, welcome to the Health Storm, everyone. Today I have Robert Longyear on. He's the VP of Digital Health and Innovation at Wanderly. Robert, thanks for doing this.
Yeah, thanks, Vic. Glad to be here.
Yeah. So just for the audience, give them a little bit about your background, what you've been up to at Wanderly, and then also previous to that.
Sure. So I'll kind of walk you through it a little bit. So I studied healthcare management and policy at Georgetown. I really got very interested in the payer side of healthcare because I really like the incentives there. Keep patients healthy, keep them out of the hospital. It's nice that it might work that way. And sort of worked for a number of Medicaid managed care organizations, from WellCare Health Plans through the National Trade Association, Medicaid Health Plans of America, and then ended up going to the Institute for Medicaid Innovation, where I managed two research portfolios. One was high-risk care coordination, and the other was social determinants of health data collection, and got very interested in the role of health information technology and health tech in how we can enhance the capabilities of sort of the traditional healthcare organizations. And it was around that time I decided to write a book. So I got called by the publisher, and they offered me the ability to write this book. And so it recently hit Amazon about a month ago. It's called Innovating for Wellness. And it really focuses on sort of this growing movement in healthcare that is value-based payment, and the need that is being created because of it for the healthcare delivery organizations to be able to effectively use data to segment their populations, to be able to change the way that care is delivered to patients in order to meet the demands of these risk-based contracts. And so essentially, I started moving in the direction of, okay, let's talk to some of these digital health companies that are able to bring better patient outcomes, reduce emergency department visits in a way that hasn't been able to be done in healthcare before, and that fits really well for value-based payment. So that's sort of the book piece. I worked for a number of digital health startups, worked for a medication management company as an app, and then I got involved with Wanderly recently. So Wanderly is the sort of market leader in contingent healthcare staffing. So Wanderly provides a kayak.com-like experience for the travel nurse, the travel healthcare professional, where they're able to staff about 1/10 of the inpatient facilities, or 1/10 of the nurses or the healthcare professionals that work in any inpatient facility are some sort of travel professional. And so from across the country, you have this workforce in healthcare that is connected via agencies for recruiting and for managed service providers to be able to bring in the various healthcare professionals for those facilities.
Yeah. Let me interrupt you. I wanted to have you on because of that background. You've been able to do all of that in a small number of years, and it strikes me that just the pace of change and the amount of new activity, innovation, new changes in the way that we reimburse healthcare is changing at an unprecedented rate, huge rate. And I think your career is somewhat symbolic of that, where in 2 or 3 years, you have worked in policy, you've worked with payers, you've worked with several different startups, you've written a book. Do you think that is fair? Is it symbolic of the times we're in?
Yeah, I think healthcare is going through a pretty significant change. I was sort of educated in the traditional healthcare way. You have hospitals, you have providers, you have physicians, you have insurance companies, but I think the lines are getting very blurred now as technology is sort of enabling more collaboration, more exchange of data. And I've really just kind of followed my interest in terms of being able to, more effectively, deliver care to patients. My interest began sort of in the biomedical sense. I wanted to go to medical school. I worked for a pharmaceutical company in gene therapy for about 1.5 years. So I was in the lab, and I decided that wasn't for me. I'm too social. But I found that, like, one of the biggest gaps in healthcare is not sort of the medical knowledge or the biomedical development. It's once you have this knowledge, how do you get it to the patient? So the delivery part and the payment part is a huge gap. And that's where you see all the headache. And I was like, this is much more of a problem than me going to medical school and being able to take care of a small group of patients. I want to be a part of a larger solution.
Yeah.
So you kind of see that as well.
It's a bigger impact if you can reach out more. Okay, so
Yep.
I want to dive into all of those things. Let's start with Wanderly, though. The travel industry is a really interesting lens because I think prior to COVID-19, there was significant nurse and physician stress and burnout. They work incredibly hard, incredibly stressful jobs. How does Wanderly first of all, do you see that? I think it's even been kind of more accelerated due to the COVID-19 stuff in some areas of the country. And then how does Wanderly try to help its people? Because y'all are working with lots of nurses, maybe not a lot of doctors. I don't know what the mix is, but it's sort of similar.
Right. So I discussed burnout a little bit in my book. I'm not a physician, so I can't necessarily speak to the experience as well. But I think there's been a lot of change happening rapidly in healthcare, and the physicians are sort of getting caught up in it. They were trained a certain way, and now a lot of it's changing, and it's I think driving a lot of change, which is contributing to the stress and the burnout. And I think that's the case for a lot of the nurses and other allied health professionals as well. I think one of the core stressors is sort of the volume demands that come from fee-for-service medicine. So you're required to see more patients. The staffing ratios are probably too high, and nurses in particular and physicians are just required to see such a high caseload that they have to do documentation for it.
It's like simultaneously more volume, more work, and less rewarding because you don't really get to know the patients well. It's just like transactional, much more.
Yeah. I remember, so part of my book, my mom passed away from chronic myeloid leukemia when I was 20. And, I distinctly remember one of the older physicians that was caring for her who said, you don't want to go to medical school. It's not what it used to be. And he really missed the patient interaction piece there with more time and the ability to sort of deliver medicine in a more personalized way. So at Wanderly, our primary group of healthcare professionals are nurses and the inpatient specialties in particular. And I know that the travel market, typically they have about 13-week or 3-month long stints in any number of jobs. And so the ability to travel and move different places, I think it's particularly appealing to a lot of the millennial nurses in that they're not stuck there. They get to go someplace else, and it may actually be beneficial in terms of burnout for nurses. But we in our line of business are not as directly involved in that as some of the actual facilities and the sort of places.
Yeah, where you might have, because of the travel industry, they're moving around enough. Whereas if you had full-time nurses, you may be more focused on trying to figure that out.
Right. And now COVID has been a huge area for us over the past 3 months, with New York needing so many nurses on the front line and New Jersey. And we've seen our network of clinicians and nurses in particular, like charging right head on into it, wanting to be a part of the solution and, really wanting to go there and to do good. So we've been sending a lot of nurses through the agencies and through our agency partners primarily to fill those jobs and help them fill the jobs in New York hospitals, New Jersey hospitals, Georgia hospitals as well.
I think it's really a calling, right? So like when you're called to help people in nursing, you want to go where the greatest need is. So that makes sense to me that in general you want to help.
Yeah, the nurses, I think I've seen the survey for the past couple of years, are the most trusted profession and most respected profession in the country because of those types of values. And so Wanderly in particular has been working with a partner to send gift cards for scrubs to our nurse partners, and really trying to support them the best we can with blog posts for how to manage stress and being able to support them as much as possible. While we can't do that much, but we've been trying our best.
Yeah. Okay. So as you know, this is called the Health Storm. Last fall, maybe around Thanksgiving or so, I started thinking about the trends coming to healthcare, and what I thought at that point was going to be a 3 to 5 year storm, really changing a lot of things in the healthcare delivery system. Of course, with COVID-19, that has all changed. I think it has accelerated the trends primarily, but I want to talk through some of the trends, just get your impression of them.
Sure.
So the first one is care moving out of the hospital to the ambulatory clinic or the neighborhood or the home. And I think that COVID is accelerating that. It already was pretty clearly in place. What's your impression of that?
Yeah, I think healthcare moving into the home has a lot of drivers. I think there was a lot of sort of policy components to it in terms of reimbursement rate changes from inpatients to ambulatory surgical centers or ambulatory care locations, just in terms of like a strictly cost perspective. But I think the bigger movement is the ability to move things into the home. I think the acceleration of mobile technology since 2008 has really become a big driver of that. Smartphones, I think I saw the Pew data is 70% of people have a smartphone, and more have some sort of cellular device, so be it SMS texting. And so I think that trend has really enabled better communication and connectivity with patients in the home, that you're able to collect data in real time, you're able to communicate in real time. And so the technology has created the environment where being able to deliver care in the home is entirely possible. It's also more interesting when you're trying to, instead of waiting for patients to getting a diagnosis in a facility, going home, hoping they're managing their care, and then maybe not going too well and then ending up in the emergency department or back in the clinic, you're able to have more frequent touch points with patients from a chronic disease perspective, or even from a post-op or a post-discharge perspective. You're able to keep monitoring and speaking with patients and maintaining those touch points to get something before it goes wrong.
Yeah, I think it's sort of all of the above, right? Like the technology is enabling it. It's largely lower cost, or there are payment drivers to sort of drive that. And I think the patient would prefer to be at home with their family around and in their in their home. They maybe have pets. There's lots of reasons that you'd rather stay at home than go to a hospital. And I think in general, assuming you can get the right care to them, it can be more holistic and better overall outcomes.
Yeah, I think like I said, the technology, I think, is kind of has created the environment where this is something people want to do for a while.
That's the enabling piece. Without that, so 20 years ago, we didn't have enough technology to do it, but now we do.
Yeah, and I think the other piece is sort of when I think about the drivers from the industry's perspective for being able to perform these services, I break them into the value-based payment side and the fee-for-service side. Under fee-for-service, CMS has opened up the chronic care management codes and RPM codes, remote patient monitoring codes, to get sort of a traditional, like we'll pay for these services now. And then under value-based payment with risk-based contracts, you have providers that now need to deliver care differently. So they now need to come up with some sort of model that allows them to meet the shared savings demands or the responsibility to care for these patients to reduce their cost. And so the driver is now putting risk on the providers to say, we got to come up with some new way, because what we've been doing is not effective. Like patients getting diagnosed, going home, hoping that it works is not working for us to do this. We need to change something to meet the demands of this.
Yeah, interesting. So, and then another trend I wanted to get your thoughts on is the kind of the market entry or new companies coming into healthcare that are not traditional healthcare companies. So the large tech firms or retail. I think before COVID we're moving in, but now I think it's going to accelerate that process. What are your thoughts about that?
Yeah, I think there's a couple of things that are at work here, and one of the other drivers that I think really affects this discussion that we're about to have is this aging population idea. It's so expensive to provide institutionalized care for older adults in skilled nursing facilities or assisted living facilities that the need to be able to provide healthcare and personal care in the home is growing. And so that's a big driver for this interest as well. And I think the tech companies, I wrote an article about this probably about a month or two ago, about how big tech is getting into healthcare. And being that the technology is so crucial to being able to do the connectivity, to collect the clinical data in the home, they are seizing that opportunity. And I think there's a big gap in the market because the traditional healthcare organizations, insurance companies, and health systems really have not given the patient and the consumers anything to be happy about. Yeah. And the tech companies, their whole philosophy is building for their end user. It's their whole sort of process, and they are very good at it. And they are a huge threat to traditional healthcare organizations because of that patient-centeredness, which the traditional healthcare system has been trying to instill in it for years. It's sort of one of the core tenets of like healthcare management policy or health services research, is the goal of being patient-centered. But the tech companies are customer-centered from the start. They build excellent user experiences, and that is a big threat.
Yeah, and I think the tech companies, obviously we're calling them tech companies, they really understand the technology enabling tools. They understand mobile, they understand data science, they understand artificial intelligence. They also understand branding and customer service in a way that health systems would like to learn about, but are not, their DNA is not centered around that. So they may be trying to move there, but they're not as a sort of core. And then I think the retail, whether it's Walmart or Kroger or CVS, they're moving into the space, and we are in those facilities, 2-3 times a week, and really know those brands, and so they're in an interesting spot too. And so almost no matter who wins, I don't know that it's a win or loss thing, there's going to be pressures on the health system, and market share is going to be sort of at least chipped away, if not radically changed.
Yeah, I think that I view this in two ways, and I talk about this in my book. There's the big tech companies that are able to come in and sort of replace. They can pull market share away. They can pull customers and patients away as they need because they're so big and they have the scale to do that. The smaller startups I see as being acquired by the traditional healthcare organizations to be able to compete with them. So what we're going to see are the United Health Groups, the Aetnas, the Humanas of the world, vertically integrating from payer and provider because we know that model works, like Kaiser Permanente or UPMC, but they still need sort of that patient engagement, patient-facing tech component because everything's going digital. So they're going to be able to acquire some of the smaller companies to be able to provide their own experiences in that realm to compete with the big tech companies. I think that's sort of what we're going to end up seeing.
Yeah, that's good for me. I like that because that means that there's lots of need for innovation to bubble up and then be acquired, which as a VC is good.
Right.
And as a founder, as an entrepreneur, is good.
Yeah. I think that it's a great way to do it. I think we've been trying to do healthcare innovation in the traditional way for a long time, and tech now is because of big tech coming in and because of the value-based payment pressures from a policy perspective, it has created the perfect storm, which I actually say in the book. So when you named the podcast that, I thought that was great. It is the perfect storm for a lot of the things that have been tried for years to actually be accomplished because of the technology coming in to be able to meet the needs and to be able to change the way that we deliver healthcare.
Yeah. Okay. So let's dive into the book. So you wrote the book. It's called Innovating for Wellness. People can get it on Amazon. I'll put the link in the comment section. But talk about the subject, and there's been a lot written about health. And so where does this differentiate? How is it new, or why should people read it?
Yeah, I think it's probably the first book that bridges the gap between value-based payment and digital health tech. And the reason I got really interested in writing a book about that was I was sitting in a research meeting with a bunch of policy researchers about a year and a half ago, and they were talking about value-based care to improve health equity, to improve healthcare delivery, and they kept saying, "Oh, we'll get data. We'll use data." And there were no
it's like this people data in the cloud somewhere in a fictional world where there's just data.
Yeah. And the policy people were like, we're just going to do this. And I was like, okay, well, here's the problem. You don't have anybody in this room that does IT, that knows how to do the data. You don't have any analytics people to risk segment your populations. I was like, you can't be kind of talking about building these programs without including them. And so that was a big gap I found in my thesis. And so I was like, okay, let's talk about a book that can talk about the value-based payments and meet the needs of the data requirements for that. And so I pulled those two together in the book.
Yeah. So, I mean, you came from kind of a policy and then digital perspective where you knew the particularly the value-based care ACO side of driving change. And then you also knew the digital health tools. And so stitching that together, I think it's really interesting.
Yeah. So, I got very interested in the ACO model about probably 5 years ago when I was first introduced to it in health economics. And, I kind of focused on studying that and learning more about it throughout my time in Georgetown and then in the research I did afterwards. And, to the ACOs that were successful or that are successful are able to change the way they deliver healthcare to patients in order to actually meet the demands of it. So for those that don't know what an ACO is, an ACO is a organization or group of providers that are responsible for a population of patients from their care, but also from a cost perspective. So instead of the fee-for-service payment model where patients come in, they get tests done, they get more visits, they make more money, that's a volume-based model. Value-based payment, like an ACO, says, okay, you guys are responsible for these number of patients and their costs, so you need to figure out how to keep them out of the hospital, essentially.
Yeah, so it's a difference between I'm going to give you a set amount of money and you care for this patient, or you maybe do that for a population of people, or I'm going to give you an amount every time you do something. Every time you turn this crank and do something, we'll pay you for that. And so obviously the incentives are very different in those different worlds.
Right. Yeah. So then there's sort of a change on the delivery side. The hospitals and the physicians are like, okay, now I can't do what I've been doing for the past 50 years. I need to come up with something new. And so they need to connect with patients more. They need to collect real-time data. They need to build new models. And so the ACOs in particular that have been successful at doing that and meeting the demands of the programs and the value-based payment models, they are doing these types of things. And so it's why that digital health, the analytics engines on electronic health records, the mobile apps, and the wearables are sort of becoming highly interesting in that regard.
Yeah. So just sticking on the ACO for a minute, it's my impression that the ones that went well, they either replaced the entire practice or it was a really significant percentage of the practice. And when they didn't go well, it was more like a bolt-on. Let's bolt on this population, but as a percent for any doc or health system, it was a very small percentage. And so there was no real need to change their entire workflow or their design. Do you think that's fair?
I think one of the core issues, I learned this from the chief research officer at Levitt Partners, David Mullestein. He says in terms of what the problem with ACOs and risk-based payment is that you still have a large percentage in any healthcare delivery organization that is still fee-for-service. So now you have some patients that you need to do something different with, and then you have some patients you still want to be coming into the clinic and filling beds. And so from a management perspective, it's tough to build your program that's scalable and cost effective if you have two very separate groups of patients with different incentives. So that's been sort of one of the problems. Some of the effective ACOs have certainly been more prescriptive with their network. And so a lot of the sort of tech-driven ACOs have built sort of medical groups and then centralized care management organizations to be able to have more touch points with patients, to have care managers talk to the patients on a more frequent basis, and that they're able to say, how's your diabetes going? How's your congestive heart failure going? We noticed that you didn't take your blood glucose earlier today because we have a connected device. Let's see if we can do that and figure out some strategies for making sure that you keep doing that and you take your insulin every day. And so those types of centralized care management functions are what have made a lot of the ACOs successful.
Yeah, so let's jump into the book. So one of the things that struck me about the book is that you come at it from a research and kind of industry expert point of view, but then there's also a significant part about your personal story and your family story about, being a caregiver for your mom and the experience of that,
Mm-hmm.
which of course is personal, but you wrote about it in the book. So hopefully you're okay sharing it.
Yep.
But it really brought, it just brought a lot more to the story or to the experience because it's much less abstract. But like
Right.
and it's true about all healthcare. That these are real people there, but often in the books it is too abstract, and we lose
Right.
that. So this was a really good kind of combination of those things. Talk to me about
Mm-hmm.
the experience of writing it, where you're sort of trying
Right.
to weave those things together.
Yeah, so there's been a lot of books written about healthcare, like you said. There's been a lot of books written about the chronic disease problem in healthcare and policy issues in healthcare and fixing U.S. healthcare. And they're all great, but they largely say the same thing. So my introduction is largely the same thing. 75% of U.S. healthcare costs are attributable to chronic disease and diabetes and hypertension and heart disease and cancer. We know that these are big problems. But I wanted to bring in the patient perspective because a lot of the innovation that happens is done for the sake of the system. And if we're going to drive real change, we need to understand the patient experience, much like what the big tech companies are doing to just kind of switch healthcare over to a more patient-centric model. And so I weaved that into the book because it's really where I learned about all the stuff that I abstractly was taught at Georgetown. So I haven't been doing this for too long. I'm pretty young, but the biggest education I've had was actually living it with a patient who had multiple chronic conditions, who was very sick, and who went through the whole journey from diagnosis to inpatient hospitalization for 2 months to home-based care to eventually hospice care. And having seen that whole continuum that normally happens over a lifetime was very condensed and very educational. And being that I was studying the topic, it was great for me to sit down and take notes and sort of remember what was going on. And I felt like it was important to share the patient perspective, to give color to a lot of this innovation that we talk about in an abstract way, just like you say. So I started out writing the book. The process with my publisher was really great. We were able to start with just stories. So I wrote my personal stories. I did interviews with people who have been leading the charge in the industry and a bunch of startups and researchers. And I was able to build those stories to make it more relatable and more friendly than just reading a thesis. My editor was like, "Don't rewrite your thesis." They're like, "Nobody wants to read that." So we made it engaging, and we built the research and some of the actual more the meat of the book around those stories so that it's more engaging and better to read.
Yeah, I mean, I think that I agree. It's much more impactful if you get a lot of people to read it and they relate to the story, and then they can understand the policy or the need for new innovation because it's tied to why it matters.
Right.
And a lot of books are, I mean, why it matters is too abstract. It's because we waste $1 trillion a year, but $1 trillion a year, even though it's a huge number, of course, 1,000 billion, is not that emotionally charged, right? Where like your mom and the experience of navigating that journey for your family and with her, and kind of how dysfunctional the system is, or how bad it is at various points along the way, because it's not designed around the patient's journey. It's designed about other things. That then sort of motivates, okay, this is why we should change it. And yes, there'll be money savings and other savings, but the real point is to impact people's lives.
Yeah, and the truth is there's like two main points in that same line of thinking. One, I was studying healthcare. We have a pretty smart family of physicians and nurses, and like we struggled every single day to navigate the healthcare system. And the whole time I was like, this is tough for me to do. This is tough for, my ICU nurse cousin to do. I'm like, this should not be like this, because the, everyday people who don't have a healthcare background are having difficulty, and they don't know what to look for.
They can't understand it. They can't navigate it. And it's not their fault. Right? Like It's like me saying, I don't understand the Google algorithm. Like, I don't need to understand it. I just need to be able to search for something and quickly, and whatever it is, a couple basis points of a second, they give me the answer.
Right.
And so for health to say, healthcare providers and hospital administrators say, it's really complicated. It is really complicated, and they need to make it simple and easy to navigate.
Yeah, absolutely. So that was sort of one of the big takeaways. But one thing that I spoke at graduation at Georgetown, and one of the things I said is like it's important to remember like the end user of healthcare, which is the patient. Like we talk about numbers and dollars all the time. It's the sort of the core of the industry. We talk about quality outcomes and metrics, which we need to be able to talk about, but each one of those is representing a patient that has a family and that has their own experience and that is sitting in a hospital bed, which nobody wants to be sitting in. Right. And so it's from my perspective important from sort of a moral and philosophical perspective. Like we're all patients. We're all going to end up there one day. And so we want it to be built in a way that reflects that. And so that's part of the message. And then the other one is if we're even from a business and from an industry perspective, if we want to stay competitive in healthcare, if you want to have a healthcare organization that survives this major period of disruption, you need to build it for the patient. The patients are the ones at the end of the day that are choosing to come there. And, outside of insurance networks and payment, your organization will survive if you're able to create a place that patients want to receive care from. And while we're not a true free market in healthcare, because of all the regulation and the different barriers, it's still, those are coming down, and it's going to still be relevant to be able to build a good experience for your patients.
Yeah, and the pressure that's going to be brought to bear in the next year, 2, 3 years of new market entry, new technology, new payment structures, probably less regulation. That is going to be challenging for the incumbents, but it's also healthy. Like it's going to drive better results, better service, better patient experience, better lower costs, better outcomes.
Yep. And I wrote an article yesterday. It's called "The New Digital Healthcare," and I basically say, look, this is our chance with COVID. We need to deliver virtual care. Hospitals need digital experiences now. I was like, we've been talking about this for a couple of years. For some people have been talking about it for decades, and it's the moment to deliver on the promises that the industry has been saying. So it's important that those outcomes and that patient-centeredness is the focus, and it actually is able to come to the goals that have been set out.
Yeah, I completely agree. So another thread of the book is, it's called Innovating for Wellness. One of the threads are the innovation process, or like how does innovation work successfully? And so talk about that. I think that's a key to us successfully navigating out of the situation we're in.
Yeah, I think there's a couple of places that comes out. One is still in this line of thinking of building for the patient. So driving innovation from patient stories and being able to say, look, this didn't go well. How can we build something that fixes this major problem or this major barrier for patients to be able to, obtain better health or adhere to their care plan or receive healthcare services. Yeah. And so being able to look from that level up and say, this is what we need to fix some of these patient problems that do inhibit their ability to maintain good health or to achieve wellness, is sort of the method that I kind of preach about. A lot of the innovation that happens in healthcare happens for business purposes or for the organization's purposes, which are not necessarily a bad thing, but it's not solving anything for the patients. And
so you would pick a typical patient or a particular individual patient and really try to understand what went well, what didn't go well, and then pull out of that opportunities to create new solutions or innovate and deliver a better experience, better care.
Right. So one of the things that I talk about quite a bit is the fact that we were seeing 5 or 6 different physicians that all had their own medical records. And so we, knowing what we know about healthcare, carried all her medical records in a pink binder. And we brought that to every appointment. And we wrote down the med lists and new prescriptions. I went home and checked them against, the interactions between the drugs. At one point, she was on 20 drugs or so on a daily basis. And we made sure that there weren't any bad interactions. And one time we found one.
Yeah, right. Because the physicians don't know all of the medicines. And then the new medicines come out all the time. So it's hard for them to keep up with all of the different interactions.
Yeah, it is. There's the drug development world has done a phenomenal job of bringing new innovations to market. But now the problem is, okay, we're going to use a whole bunch of these in patients. And so that's one of the core problems I talk about. The ability for providers to communicate, the sharing of data, which has now been opened up due to some federal rulemaking in terms of electronic health record data sharing through the FHIR API. So those types of regulations have really helped in that area, and we'll have to see what happens there too.
Yeah. So part of it is sort of starting with the right challenge. Like if we're going to innovate and make a new solution, let's do something that's needed. That's the first piece. And then how do you recommend actual innovators approach it? I think a lot of people in my audience, a lot of people in general, feel like there's like this magic innovative thing where you just like snap your fingers and it works because they watched the Social Network movie and it seemed pretty easy and that's all they know. But it's actually not really like that. There's a lot of iteration and process. So talk about that.
Yeah. So I think the first piece and like what I like to talk about in healthcare is building from that patient level. But there's other ways to go about it. I think the core difficulty in healthcare is that you're dealing with sort of business issues, you're dealing with people issues, and you're dealing with sort of the clinical elements, which are extremely complicated. Being able to bring together varying perspectives on this, once you've sort of said, hey, this was a big problem for my patients, being able to take that and pull together the different expertise you need to actually attack that problem.
You have a researcher, you have a clinician, you have a finance person, and a patient experience person.
And so I've seen some of the best companies have brought together people that are passionate about the same problem and that have varying expertise. From, if you're talking about tech innovation, you have the tech people, you have the business people, and you have the people who have sort of a finance background or access to capital to be able to fund it all. So those have been very successful, but the ones that I've seen that have been the most successful are the ones that truly are able to deliver better patient outcomes, better patient experience, and one thing that's core in healthcare is making sure that the physicians and the other healthcare providers are happy with it. So building for them to not just the patient, but the provider experience, because we are still locked into a very physician-driven healthcare system. So making sure that what you build doesn't disrupt their workflows too much, doesn't contribute to burnout, and is clinically relevant is also very important.
Yeah, so that's helpful. Talk about the opposite side of that. So, like, where does it go wrong? What around innovation would not be helpful, or have you seen bad examples of?
Yeah, I've seen a couple where I see a lot of companies that will look at something very single-mindedly. That's not the right word, but looking at something from one perspective. Healthcare is extremely, the joke through people who study healthcare is healthcare is very complicated and it's very complex. It really is. And you have a really deeply rooted institutional science that is medicine involved. You have the new technologies that come in from a biotech perspective. You have payments, so you have a very strong finance element, and you have obviously the patients, which are consumers. So you're not just like a B2B company, you oftentimes are a B2B2C company, or a lot of times you're working in an organization that you have to understand how it impacts upstream and downstream factors. So a lot of companies will say, oh, I'm going to do this. And it's like, well, somebody doesn't get paid for that, or they're not going to be able to fit that into their workflows, or that's actually not very clinically relevant for a medical perspective. It might make sense from workflows, but they're not actually going to be able to use that for patients. And so I've seen a lot of companies.
You only have one expert at the table. They don't know how to build the innovation that could really solve the problem. You need all the different stakeholders contributing.
Yeah, because there's so many, there's so many healthcare specialists and professionals that are actually involved in healthcare delivery. There's so many upstream and downstream organizations that everything impacts each other. And so you really need to get a grasp on, if I put this someplace, what's it going to do to everybody else, both upstream and downstream. So when people come at it with just, I saw this happen, and this is one of the risks of going from just a patient perspective too. I saw this happen, I want to fix it, but they don't understand what this means from an organizational perspective is also a bad thing. So it's important to be able to have sort of a holistic perspective when approaching, is particularly in healthcare. If you're looking at a lot of other industries, a lot of times you don't have as many contingent factors. So you're able to kind of.
I think that's right. Like I talk about the value network a lot, and what I mean by that is the network of companies and people and services that are stitched together to deliver a value to a customer. So,
right.
If you take the taxi industry being disrupted and shifting to rideshare, Uber and Lyft and others, they sort of lifted out the entire value network and delivered it on an app, right? So you have, as the user, I order the ride, I pay for the ride, I track the ride, everything is done very cleanly, and so I never have to interact with the old taxi system if I don't choose to.
Right.
And that is clean. I mean, you have to do it well, but it's clean. In healthcare, if you're going to try to do that with ambulances, there's the whole. It's very intertwined, right? They have the 911 systems. The ambulances have to know where to go. There's a whole infrastructure, and then it's not paid for by the person getting the ambulance. It's reimbursed. So you have a very more complicated value network.
Right.
And if you're going to innovate in that world, you have to be able to insert your piece in a way that all the other systems interact with, or it fails. It doesn't work. So that's just the different way of saying what you're saying, but that's how I think about it.
Yeah, I think what I talk about in the book is these specialization silos make it extremely difficult to kind of insert yourself. It creates opportunity because you can blur the line sometimes to create nice value for everybody in the network or the value chain, but you have to understand it to be able to do that well. Yeah. One of the companies that I talk about is Unite Us. They're a social needs IT platform, or a platform for managing that type of work. And to give a little bit of background, there's been this growing movement in healthcare, which I read a paper about at the Institute for Medicaid Innovation, called the social determinants of health. So these are things like poverty, food insecurity, homelessness that affect people's ability to manage their conditions, or that actually cause conditions in the first place. And first of all, in my book I say, well, duh. If you have somebody who can't afford healthcare and who's homeless, they're going to have worse health than other people. So it's just gotten into sort of the academic literature in healthcare services and health policy that it's become a big movement. But what Unite Us did is say, look. Yeah.
So anyway, go ahead. I have challenges with that whole meme that's out there, but that's okay. So what talk about Unite Us.
Yeah, so what they did was they have a platform that connects community-based organizations, which is the policy term for like social needs organizations like food banks and housing not agencies. I can't remember what they're called. Sort of the housing organizations and the social support organizations that exist, and the healthcare facilities as well, so that they're able to better coordinate for patients who come to the emergency department, let's say, and they don't have a house, and so you're able to connect them with an organization that may be able to help them find housing or support there.
Yeah. So they don't have to do all that work. What they do is sort of stitch together the sort of collage of other services that are already out there, but people have trouble finding.
And this goes really well with our previous conversation, which is like a lot of times, and a lot of the innovation that I'm most interested in is not the let's build a new medical device or product to treat a condition. It's okay, patients are existing in this healthcare system. How can we better manage their care and coordinate and connect and share data and communicate to fix a lot of the problems than just making sure they have a new pill for something. So
Yeah, and
that space is big.
the systems and services are already in place. They don't need to be reinvented, but they do
Right.
need to be, you need help navigating, or you need help
Yeah.
connecting the right person with the need to the supplier that can do that.
Right. Exactly. Yeah. A lot of the stuff that we do because of specialization in healthcare and in sort of the larger, I guess, human services ecosystem is already done by some organization somewhere. And so it's a matter of connecting knowledge and resources to patients that need them more efficiently. And a lot of the bigger health systems and bigger insurers are like, we're going to do everything, which from a business perspective with horizontal integration, it makes a little bit of sense. But from a perspective of being efficient with the larger system's resources, a lot of times you just need something that better connects or better shares resources or is able to more efficiently allocate them. And so those types of innovations are also very effective. So the hospital doesn't have to provide housing. They don't need to build a hotel or an apartment complex if they're able to connect with some organizations and resources that already have that.
Yeah,
and
right.
so that's where the specialization can be broken down through better communication that's often facilitated by tech platforms or IT.
Right. Okay, so I want to jump to talk about the shift over the next couple of years from I'm going to call it reactive care. So I get sick, I have symptoms of something, and so I call my doctor, I go into an urgent care facility, I go into the ED, I go somewhere, and then the system reacts to that.
Right.
That's sort of largely what we have now.
Yeah.
People call it sick care. I'm choosing to call it reactive care because sick care is a little bit negative sounding. But that's the way that most of the interactions happen.
Yeah.
And I think we all would agree that if we can get proactive and preventative, and I take care of myself more so that I am healthier for longer, that is less expensive and better for the patients.
Yes.
But the transition is hard, right? So if we start doing proactive preventative care, that might solve the need for a lot of healthcare services in 5 years or 10 years. But tomorrow, there's still going to be people that need reactive care. And so talk about that transition, because I see it as really needed. We have to make the transition, but it's going to be more money, not less, in that transition time.
Yeah, I agree with you there. I think so I'm a big fan of this terminology, reactive to proactive, and it's one of the core themes of the book as well. Now that value-based payment has come along, it really has set the stage for more proactive care. Prior to that, you still want patients coming into your hospital to fill beds because you get paid for it.
You lose money. You can't meet your bond payments if you right.
Exactly. So now that that's come along, and this is part of the reason why the book became relevant or able to be written, now there's this interest in being able to do this that wasn't previously incentivized in the system. Yeah. And so let's take the typical chronic disease patient. Let's take, we'll use my mom as an example. She was diagnosed about, at this point, 10 years ago with chronic myeloid leukemia. It's a cancer, it's a leukemia, but it's able to be treated with 2 pills a day. Because of some remarkable research and development in biotech. And so these drugs called tyrosine kinase inhibitors are taken in the morning and at night, and it pretty much manages the cancer pretty effectively. But from the point she was first diagnosed, she started going in once she reached a level of remission to have about every 2 months a visit with blood work to keep things checked and to make sure that everything was going smoothly. And so for a lot of chronic disease patients, they're able to do that, and they go in and see their physicians probably every 3 months. So a lot of patients with diabetes will go see their endocrinologist every 3 months for a checkup, and they'll go through some of the evidence-based clinical strategies there. But now on the continuum of touch points with patients, you now are able to use technology to get more touch points with patients. And so, and with touch points, you get data.
You get information daily and get a much better view of how things are progressing.
Exactly. I mean, on the far end of the continuum, you can have diabetics that check their insulin every hour, and you're able to manage them every hour. And that data is able to be fed to their endocrinologists, who make it an automated alert saying this patient has been, hyperglycemic for 3 of their last, 4 tests. You may want to reach out to them. And so in the current system, and this is changing, like we're discussing, but in the current system, that patient may be allowed without any support to be hyperglycemic, have to call 911 and then go to the emergency department.
Yeah.
But now, if we're able to see that within the hour,
they might be trending that way over days or weeks before they really have the crisis event.
Yeah. And then in that case, you can step in before and say, what's keeping you from doing this? Is it cost? Is it just not knowing how to take your meds? Is it forgetting to take your meds? What's going on here? Yeah. And so in that regard, you're able to correct before it ends up at those costly points of care, which is what we're all concerned about, the emergency department and the inpatient hospitalizations, because patient's condition got so bad that they need to be in the hospital for a week, which costs, a couple $100,000. Yeah. So that's part of it.
Yeah, and I think we've been sort of talking about it, but not as intentional during this hour. I think the language that we use is really important, right? So calling something sick care is derogatory versus calling it reactive is not derogatory, right? It just is what it is. Someone is in crisis, and we need to take care of them. And then same with, I've been starting to trend towards using the alignment of incentives so that we align the payment structure with what we want for patient care, as opposed to value and volume, because value and volume are so anchored. People already know what they think about that. Like, they are supportive and passionate for value, or they're against it because it's never going to work, and they don't really listen after that. And so whether that's right or not, I don't know that I care. I've been switching over to let's align interests so that everyone is working in the same direction.
Right.
That's sort of what value is trying to do, but it's not as charged. And people can buy into that. Yes, let's all row in the same direction. Certainly. What does that mean? So.
Yeah, I agree with you on that one. I think a lot of times you run into this issue where the reimbursement stuff was holding back a lot of this interest. Like I've said a couple of times, but now that you've gotten to an ACO type model, the incentives for the delivery system and the payment system are now aligned, and now it's time to bring the patient involved to that. And I think one of the core problems, which is why I wanted to write this book, was a lot of the physicians and the frontline delivery organizations were saying, we don't know how to do this. Patients, we can't control anything with the patients once they leave our office. They come into our four walls of our building, and we do our best and we do all the evidence-based stuff we know, but we can't do anything once they leave. And so now the so-called last mile healthcare is being bridged with mobile technology and work like that. And that's sort of the continuum that I hope continues.
Yeah, and I think probably the clearest example to me is in COVID. We went from telehealth is really complicated regulatory environment. Licensure is state by state, and so if you're you live in the DC area, if you're in DC and treating patients in Maryland and Virginia, you have to be licensed all over the place, and it's not really reimbursed, not paid for.
Right.
And so with COVID, it's wartime. We have to figure out how to deal with this right now. They opened that up, and now it's 50 state license, and we pay them. And I think I've seen docs of all different specialties very supportive of telemedicine, because it's better for the patient, better for them. They're paid. They don't have to worry about licensing issues. And so a lot of it in the adoption is kind of legacy things that have to be worked through in the regulatory environment or the reimbursement environment.
Yeah, I think that the regulatory, this is another element that makes healthcare very complicated, is a lot of people approach it and they say, oh, I want to do this, but they don't realize that there's a lot of state and federal regulation that keeps them from doing it. I've worked with some companies that are trying to get reimbursement for their new technologies, and they build the technologies, and I'm like, nobody pays for that. And so it's much more challenging when you have innovations, and this is a good example of another innovation that doesn't work. There's a lot of people that come in and say, this was a problem, I want to fix it, but they don't know, or they aren't paying attention to sort of the payment environment, and they want to get reimbursement from payers, but a lot of times it's like that is not something that is currently paid for. So it's much tougher there. I think the changes recently in terms of telehealth have been very good. from an access perspective. So a lot of people in rural areas and a lot of people who might work 9 to 5 and can't take PTO to go to a physician visit are able to be getting care in their home now, and to at least have some touch point with a physician. And we know that you can't do everything over video, but you can do a lot, and it's better than not having one.
Yeah.
And a lot of
I don't think we're putting the genie back in the bottle. Like I think we have seen the power of telehealth. I don't think it's going to go backwards. I think the patients like it, the doctors like it, and it's just going to be like part of the new normal world.
Right. I believe I saw that the CMS administrator, Seema Verma, she mentioned that it's not going back. That was her comment. I believe I saw in some publication a couple of days ago. She said apparently it's working, which a lot of people in the who've been working in this space for a while have been like, well, we've been trying to do
not
this
surprising
for
it
years.
didn't work, but at least we know it works now. So let's continue forward.
Yeah. It's like, you mean we can connect with patients that don't have physicians near them with video chat? It's like, yeah, we can now.
So talk about the other trends that you see out there. We don't have that much time left, but just in general, what else are you seeing that we haven't been able to touch on?
Yeah, I think some of the big stuff will be AI and machine learning, natural language processing that's coming into sort of the electronic health record space. One of the big pain points is the use of clinical data in healthcare. Epic and Cerner are sort of the two market leaders in terms of the big inpatient electronic health records, and physicians and the healthcare professionals don't like their UX.
Yeah.
So there's been a lot of interest in improving that piece, and the ability to take that data and to derive a lot of good insights into patient conditions and to risk stratify and to predict some of these things we're talking about. So if we're able to collect more data from patients, then we're going to be able to say, okay, we have all this data. This patient's more likely to end up in the emergency department in 2 months. So we need to, really build good program around that patient. Yeah. So that's one. I think a lot of the IT infrastructure in terms of some of this mobile health and the remote patient monitoring we're seeing is built around connectivity to electronic health records. So they will be sort of the central marketplace for a lot of these technologies to connect. So we're going to see a lot of connection there, a lot of middleware companies popping up to be able to do that. And then sort of building this sort of patient through physician through analytics, like IT infrastructure, essentially.
Yeah, so it strikes me that in both of those, Epic and Cerner are going to be the bottleneck or the enabling point for that effort. I mean, I hope they're the enabling point. It would sort of give their platforms much more value. If they try to be the bottleneck, I think there's going to be other solutions that end up sort of building facades on top of them, to sort of get to the value that we all need.
Yeah, I think the regulation that just came out of the Office of the National Coordinator really sort of clarified.
Yeah, right.
Yeah, it's forced that a little bit. I think what we're actually going to see is a lot of the bigger electronic health records are going to start doing a lot of M&A for some of the mobile health companies, some of the patient engagement companies. We've already seen a little bit of that, but they're all going to want to have their apps and their digital health tech to be able, because they're already in with a lot of the health systems. So it's going to be another value add to add on top of that to remain competitive.
Yeah.
And then one of the rumors that, and I've seen a video, so it's less of a rumor, is Google's moving into the electronic health record space.
Oh yeah, there's no question. I mean, they're building, I think, an overlay on top of Epic and Cerner and Athena and all the different platforms, so that you would have one interface, and of course it's Google, so it'll be a really intuitive, great interface. And it'll either put pressure on Cerner and Epic to sort of upgrade themselves and become better UX, or it will become the standard, probably a little bit of both, right? And so great.
I think another big trend, so I talk a lot about Amazon. I think another big trend is voice technology. So using Alexa and Google Home to be able to better connect with patients. So for older adults that make up a lot of our healthcare costs and that develop chronic conditions later in life from the diseases of aging, it's more natural for them to be able to communicate with Alexa or with a Google Home based system for data collection and post-op check-ins. So a good example of this is Boston Children's Hospital has a program that's built on Alexa, where children who are discharged after surgery are able to, and their parents in particular, are able to like check in with their care team. So that the Alexa will be like, oh, how is your pain today? They'll be able to do a scale of 0 to 10, and that data is relayed back in a pretty engaging way. So that's another big trend I see happening. I know Google and
those, the artificial intelligence behind those are getting stronger and stronger daily, right? So more and more of the inputs can be sort of automated, and you can get through much more interactions without humans, and then there's sort of a exception-based human interaction.
Right. Yeah. So I think that that type of technology, the true like spoken natural language processing, is going to be pretty big, particularly as well for dictation in sort of the clinical setting. So I know Amazon may already have this out, but you're able to, physicians can be talking and it'll input the data into the electronic health record through voice. So they're not sitting at their computer while they're doing it.
Yeah, but I've tested it. It's not as strong as you really would need to get wide adoption, but they're, Amazon is quickly making it better. And so I don't know when it'll be ready, but they're moving very quickly on that.
Yeah, absolutely. I think Amazon Care is focused on the employer market. So they'll be providing telehealth and chronic disease management to their employees, and they'll likely scale that out to other companies after testing it internally, like they did with AWS.
Yeah, so Amazon Care is interesting from the referral network's point of view. So I think they will certainly broaden to lots of employers, probably with JP Morgan and Berkshire Hathaway at first, which is in itself pretty big number of employees.
Absolutely.
But I'm interested in your thoughts about the referral patterns. Right? If all the primary care is done through those private enterprises, might they then use that buying power to push volume to particular cardiovascular centers, or particular diabetes centers, or particular knee and hip areas, or different.
I think that's likely. I think we've seen that already. So like Walmart, for example, has their center of excellence for spinal or back surgery for their covered lives. And I know that those centers of excellence there's employer-based programs are already funneling them to be high volume, high quality, and lower cost facilities. And they're even flying patients out to those facilities. They're putting them up in a hotel. They're taking care of them from start to finish. And it's still cheaper than going to the local facilities as well.
Yeah, it's cheaper and it's better medicine for the patients. Both.
Yep.
Yeah.
Yep.
Good. Okay, so Robert, you've been working on this for several years. What do you wish you knew when you first started at Georgetown, trying to get into it, that you know now?
Yeah, I wish that I took more computer science classes. I'll tell you that much. If I knew I was going to be in the tech space, I certainly would have done that. Probably would have gotten a minor.
Not too late. You can still work on
it. Yeah, that might be on the roadmap going forward. I definitely feel a little bit like when I'm talking about product features or working in one of the spaces, I feel like I need to have my hands in something a little bit more. So I think that's a piece. When I wrote the book, the thing that I thought I knew what I knew, and then I started writing the book, and I was like, oh man, I want to include more in here, but I don't know about it. And so like the process of writing the book, you think is a very educating process, but I think I learned that I know less than I think I do through that process. So I think I learned that there's just a whole lot out there. And that's probably the biggest thing I took away from it was I didn't necessarily, I learned more about what I didn't know than what I do know.
Yeah. Interesting. So as you learn more, there's more and more questions almost. Yes. Or how to influence behavior and how to change the system gets more and more complex. The more you see, it's just like a level of focus, the more that you see all the different things that need to be worked on.
Absolutely. Yeah. The toughest part for the book is scoping. So being able to say, I'm only talking about this, or I'm swimming in this lane, not getting into these other things is really tough. And so that was definitely a big part of it.
Well, Robert, thanks for doing this. I've really enjoyed it. People, I will put a link for your book, but it's Innovating for Wellness on Amazon. It's going to be a nationwide bestseller soon, and so get it now before they run out.
I hope so. It's made it to #1 in healthcare administration and healthcare informatics on Amazon so far. So hopefully stays there.
Yeah, great. Thanks for doing this, Robert. Appreciate it. In these crazy times, you fit an hour in, and let us know how things evolve.
Yep, absolutely. Thanks, Vic.
All right, bye.